would like to wait? There might be some people are joining, or you would like to start?
We will start now. We are broadcasting to YouTube.
Okay.
Hello everyone and welcome to our final session of the Oral and Maxillofacial Surgery webinar series. My name is Omar and I am the webinar director at the SCORE committee. It's a pleasure to have you all with us today. Before we begin, I would like to briefly introduce the International Association of Dental Students, IADS. IADS is the largest global organization representing dental students worldwide, connecting students from different countries and creating a platform for academic exchange, professional development, and cultural collaboration. This webinar series is organized under the SCORE Office of IADS, which focuses on research, education, and international collaboration, providing valuable global learning opportunities for dental students. As this is the final session of this series, we would like to thank all of you for your participation and engagement throughout this oral and maxillofacial surgery webinar series. We hope you have found these sessions insightful and beneficial. And it's a great pleasure to welcome Dr. Faez today, and we sincerely thank him for joining us and sharing his expertise. To introduce our speaker and guide us through the session, I would like now to hand over to my colleague Adham.
Thanks, Sommer. Today's topic is local hemostatic agents in oral surgery, clinical applications, and evidence-based considerations. And presented by Dr. Faez Saleh. Dr. Faez is an assistant professor in oral surgery at the College of Dental Medicine, University of Qatar, a specialist at Hamad Medical Corporation, graduated from Aleppo University, Syria. He completed his specialty training in oral surgery at Mansoura University in Egypt. He earned his PhD degree in craniofacial health sciences in 2021 from McGill University, Canada. He studied a postdoctoral fellowship on temporomandibular disorders at McGill University in August 2022. The floor is all yours now, Doctor.
Thank you, Adham and Omar, for the introduction, and I would like to thank the International Association of Dental Students for this opportunity. It's a pleasure to be with you today.
Thank you, Doctor.
Welcome. You see my screen now?
Yes, Doctor.
All right. So today, inshallah, we will be talking about the local hemostatic agent used in oral surgery, clinical application, and evidence-based consideration. Basically, I will be covering the following learning objectives. So you will be able to recognize the types of hemostatic measures used in oral surgery, recognize the rationale, why we do use these hemostatic measures in oral surgery, their advantages and disadvantages, and to discuss the recent evidence regarding the most effective local hemostatic measures that can be used in oral surgery. I'd like to declare no conflict of interest. So basically, if a patient comes to you and this patient requires a tooth extraction, there are many complications that you might encounter in a dental clinic for a patient that requires a tooth extraction. Any volunteer who can list what are the potential complications after tooth extraction? All right. So basically, if a patient comes require a tooth extraction, the patient might have a pain, swelling, trismus, tooth fracture, jaw fracture, bleeding, ecchymosis, etc., etc. But there are certain group of patients that might have a higher risk of bleeding after tooth extraction, and these patients are medically compromised patients. Basically, it include patients who have deep vein thrombosis, patient with a high risk of pulmonary embolism, cardiac arrhythmias, patient with stroke, myocardial infarction, those with coagulation disorders such as hemophilia, patient with liver disease, liver cirrhosis. And many of these patients, basically the cardiac patient and those with stroke and MI, myocardial infarction, they most likely consuming antithrombotic therapy, which is a medication that prevents the clotting of their blood. Therefore, the risk of bleeding in such group of patients is high. So before we study the hemostatic agent, we would like to know what are the types of oral anticoagulant and antiplatelets that might impact the bleeding in these patients. So basically, we have three classes. The first one is the anticoagulant, and these drugs act mainly as a vitamin K antagonist, such as warfarin, and we have the antiplatelet agents such as aspirin. Basically, these medication prevent platelet adhesion, platelet aggregation, secretion, etc., etc. And we have the last one, we have the direct acting oral anticoagulant, which mainly blocking the thrombin inhibitors or factor 10 inhibitors. In the other table here, we have the specific mechanism for each type of anticoagulant. For example, we have the vitamin K antagonist, such as warfarin, and this one, it inhibits vitamin K epoxide reductase. Basically, this drug, it reduces the synthesis of factor 2, factor 7, and factor 9 and 10. And the effect of this drug, it lasts from 36 to 42 hours. Also, it extends to 5 to 6 days. So this is the warfarin. Then we have the heparin. The heparin, it inhibits factor 10 via antithrombin, and it is action lasts for 4 to 6 hours. Then we have the direct factor 10 inhibitors. We have also thrombin inhibitors, as well as we have the antiplatelets drugs such as the COX-1, the COX inhibitors, and prostaglandin 12 inhibitors. And these acts mainly by inhibition platelet aggregation, secretion, and activation. So once the platelets got influenced by these medication, then the effect will last for around 7 to 10 days, the lifespan of platelets. If you have any questions, feel free to interrupt me. So, and general principles, if a patient comes to you and this patient taking antithrombotic, antiplatelet, or anticoagulant medication, so any patient also, any type of patient, we need really to carefully assess their medical history and their current medication, if in their diet. For example, some diet supplements such as the garlic, it is a blood thinner. It increases the risk of bleeding. So we need to assess medical history, what are the disease, if they have cardiac disease, stroke, etc., what type of medication, is it aspirin, is it heparin, is it antiplatelet medication, and any supplement that might impact the bleeding risk. And the bottom line here, never modify or stop patient medication. It is fundamental that we don't interfere with the patient medical medication, prescribed medication. Then we need to be aware of the surgical anatomy. So bleeding can occur not only because of the systemic condition, but because of the malpractice or improper use of instrument. For example, using the elevator in the palatal side of the tooth, and sudden slippage of the elevator in the palatal mucosa might cause serious injury, endangering the greater palatine artery. So we need to be aware of the surgical anatomy, and also we need to assess the type of the procedure. Are you going to do a simple extraction with a grade 4 mobility tooth? Is it a surgical extraction? Are you planning to extract single tooth or multiple teeth? It is vital to have a good access and lighting, also to minimizing the surgical trauma as possible. If you are doing a tooth extraction, it is also a good idea to use a local anesthesia with a vasoconstrictor to reduce the blood oozing, so it enhances your vision during the surgical procedure. For such a group of patients, we might use the hemostatic measures, and this ranges from pressure back suturing, use of a local hemostatic agent, which will be discussed later, electrocategory, blood vessel ligation, and systemic hemostatic agent. Mostly in dentistry, we'll be mainly using these ones, pressure back and suturing, and use of local hemostatic agents. So hemostatic measures, it can be divided into 3 or 4 groups. The mechanical, such as pressure back gauze, suturing, biological agents such as collagen plug, fibrin sealants, platelet fibrin, pharmacological agent which can be used systemic or locally such as tranexamic acid, and we have other agents such as gelatin sponge, oxidized cellulose, which acts basically as a scaffold and has physical properties that enhance clot formation. So these are different types of the most commonly used hemostatic agent. We have, for example, Ankfor blood stopper, which is a herbal product. We have the oxidized regenerated cellulose, chitosan dressing. We have the collagen plug, gelatin sponge, and platelet fibrin. So we will discuss these ones in details. So for example, we have the Surgicel. Surgicel is actually commonly used in our clinic. It is an oxidized regenerated cellulose preparation. It binds hemoglobin to oxycellulose, which acts as a scaffolding for clot formation and clot stabilizer. Thus, it enhances the clot formed at the socket. It is absorbable, and it's actually rapid absorption. It will take 1 to 2 weeks to absorb. So basically, it's really does not really interfere with healing, or it has also a low risk of infection compared to other drugs, to other hemostatic measures. So the other one we do have at our clinic, gel foam. It is water insoluble sponge prepared from bovine porcine skin gelatin. It aids clot formation by releasing thromboplastin from the platelets. Thus, it provides a structural support for the forming clot. However, this one, the absorption of it takes 4 to 6 weeks, and it might be associated with increased risk of infection compared to the other ones. Then we have the collagen. Collagen is also derived from bovine origin. It facilitates platelet aggregation and degranulation, and it enhances also the stabilization of the clot. It provides a 3D matrix for additional strengthening of the clot. However, the collagen associated with increased risk of infection, and it might also associated with delayed healing. If you look here, we have the collagen, which is animal derived. We have the gel foam, also it is animal derived. So patient decision, we should also consider patient decision in this cases, because some patients, they might not agree to have an animal product applied in their jaws. So we might think of an alternative. So the alternative we have here, the thrombin. Thrombin is a recombinant human thrombin. It cleaves fibrinogen into fibrin. It promotes platelet activation and aggregation. It comes as a liquid that you can apply in, let's say, a gelatin sponge or in a collagen or in a gel foam, which absorb it and enhance the clot formation. Can be used in a combination with other hemostatic, or it can be used as a dual system of fibrin and thrombin as a glue. So you have both fibrin and thrombin, and you mix them and you inject them as a glue. Also, we have a bone wax. Bone wax is basically a mixture of beeswax, paraffin, and isopropanolate, which enhance the usability of this mixture. It acts as a mechanical sealant. Basically, if there is a bleeding, oozing from a bone, so this one, it acts as a mechanical sealant, tampon. It does not act biochemically, and it is non-resorbable. Therefore, there is a risk of foreign body reaction and granuloma. Basically, this one, you can coat the bleeding surface with 1 or 1.5 grams by knitting with fingers. So you apply it in the socket or in the bone that's bleeding, and then you block the bleeding. Maybe at the end of the procedure, you can remove it if hemostasis is achieved. If you lift it, there is a risk of foreign body reaction. Then we do have the tranexamic acid. Tranexamic acid is an antifibrinolytic medication. So basically, it enhances the stabilization of the clot. And it can be used as a mouthwash or as a systemic injection, intramuscular injection, which can enhance the stabilization of the clot in case of there is severe bleeding. So let's say that a patient comes to you, and this patient, you perform tooth extraction. So we can categorize these patients into two groups. Healthy patient, if you did an extraction in a healthy patient, basically the natural body response will enhance the clotting. So pressure back goes is more than enough. Pressure back goes and suturing if needed is more than enough. But in some cases, you might apply hemostatic agent. The second, so patient taking antithrombotic drug or at risk of bleeding, those with systemic condition, such as coagulation disorders, or those with taking antithrombotic medication. So pressure back might not be the standard of care, might not be the only option that we need to apply in these patients. So it is actually a good idea, fundamental, that we apply extra measures to prevent the bleeding. So you can apply pressure back. You can back the socket with hemostatic agent and the suture. And we need to ensure that hemostasis must be achieved before the patient left the clinic. So after 10 minutes of placing the pressure back and the hemostatic agent, so you need to check. If the hemostasis is achieved, then you can dismiss the patient. Otherwise, you need to place another back. Analgesia, so if you perform a tooth extraction and you expect pain, so paracetamol is preferred as it is a central analgesic. However, aspirin, if you use aspirin, it might also induce the more bleeding. So it's a good idea to avoid aspirin. However, in cases of severe inflammation and you need to have a better analgesic effect, you might use opioids, or you might use ibuprofen. But for short term, it's less likely actually to impact the bleeding. So the question that we have, whether to stop or not to stop the anticoagulant therapy. So let's just dig into details. The procedure type. So we have low risk of bleeding, such as if you are doing administration of local anesthesia, thimble restoration, supragingival scaling, or single tooth extraction. So the bleeding risk here is minimum. We have a moderate risk if you are extracting 2 to 4 teeth or periodontal surgery. So patient might use different types of antithrombotics, such as aspirin, warfarin. So we need also to check. So the INR, so the therapeutic range of the INR that we can perform a tooth extraction in an outpatient dental clinic should be 3 or below 3 or 3.5. If the INR below 3 and 3.5, we can proceed with the dental treatment or tooth extraction, continue without modifying patient drugs, according to the clinical practice statement from the American Academy of Oral Medicine and American Academy of Neurology. For a high risk of patient, if you are doing, let's say, surgical extraction of multiple teeth or excision of an oral lesion or a cyst enucleation or resection of part of the mandible, then we need to assess the risk of bleeding in these patients. So healthcare provider who perform invasive or surgical procedure are concerned about pre-procedural and post-procedural bleeding should contact the patient cardiologist regarding the antiplatelet regime and discuss optimal patient management before discontinuing antiplatelet medication. So it is fundamental that we contact the patient physician when there is a concern. If we have a concerns regarding the post-operative or perioperative procedure bleeding, then we consult the patient physician rather than we stop the medication by ourselves. So let's have two case studies. So case one, we have the patient 65 years old. The patient has atrial fibrillation and is taking warfarin, and also the patient diagnosis with hypertension, well-controlled hypertension, and he's taking warfarin 5 milligrams daily and anti-hypertension medication. There's no allergies. The INR is 4. Dental issue, the patient complain of a painful, non-restorable mandibular left first molar. The procedure that you plan to do is simple extraction of this tooth. So what we should do in this case, should we proceed? Should we consult the patient physician? Should we stop their medication? According to the guidelines, the INR of this patient is in the therapeutic range where we can proceed with the simple tooth extraction. So basically, you can proceed with the simple tooth extraction, applying pressure back gauze and local hemostatic measure. Hopefully, this will control the bleeding for this patient. The other case here is a 50 years old male, and the patient had a stroke recently, a stroke 6 months ago, and is taking aspirin. And the aspirin that the patient is taking 80 to 100 milligrams, the INR is 1.1. Basically, aspirin is less likely to impact the INR. The dental issue, the patient has multiple grade 3 and 4 mandibular teeth and needs simple extraction for 3 teeth, surgical extraction for 1 tooth. And the INR is 1.1. So we need to wait whether to discontinue the risk of discontinue the systemic medication versus the risk of bleeding. So if you look here for this patient, the INR is 1.1, so almost normal. So this patient, you might proceed with the dental extraction, tooth extraction. You might start by doing, let's say, segmental extraction, extract 1 or 2 teeth, and then assess, apply local hemostatic measure, and then in the next visit, you extract the other teeth. But there is no need to discontinue the patient medication. So regarding the current evidence, what is the most effective local hemostatic agent in managing post-extraction bleeding in patients in antithrombotic medication? Up to date, actually, there is a lack of evidence to support which type of hemostatic agent that we can choose to control bleeding in patients taking antithrombotic medication. And therefore, I came with a group of my students here in Qatar University. We're designing a network meta-analysis study to identify the most effective local hemostatic agent for controlling post-operative bleeding after dental extraction, to compare agent based on time to reach hemostasis, sucked healing, and post-operative pain. Basically, in this study, it's a systematic review and network meta-analysis. We focus on only on randomized controlled studies, and the protocol has been registered Hopefully, we will submit this article in the coming month. The inclusion criteria, according to the BICO participant, we include adult patient under oral antithrombotic requiring tooth extraction, whether simple or surgical extraction. The intervention, different local hemostatic measures. The comparison, the most common hemostatic agent, which basically is chitosan. And the outcomes, time to reach hemostasis, the primary outcome, secondary outcome include pain, alpha-ostitis, perioperative bleeding, and socket healing. And the study design in this is the systematic review include only RCTs. So if you look here, we searched multiple databases and a total of 32 articles included in our study. This is the quality assessment according to the risk of bias tool, Cochrane risk of bias tools. Overall, we have 9 studies that rated to have low risk of bias, 13 studies that has high risk of bias, and 14 studies that has, 12 studies that have unclear risk of bias. So for the quantitative analysis, which is the network analysis, the first outcome was time to reach homeostasis. If you look here, this is the network plot, which is represented by the names of the intervention and lines, nodes. So the thicker the line, the more comparison that we have. The most common comparator was the chitosan. And this is the first plot using random effect model, which were all these intervention has been compared to the chitosan. So basically, if you look here, the collagen and collagen with suture has a lower time to reach hemostasis compared to the chitosan. So basically, they produce hemostasis quicker than the chitosan. So you can interpret from the negative values here. And if you compare here, we have the pressure back goes and suture. Chitos, they reach hemostasis in a prolonged duration around like 10 minutes, for example, here, and the pressure back goes and sutures. So basically, chitosan is more effective, significantly better than these measures. And if you look here, this is the rankogram. So the higher the number, closer to the one, the better the performance of the drug or of the intervention. So we have the collagen followed by collagen with suture, followed by chitosan was ranked the first, and then we have the other treatments. And here to the right, we have the final plot, which assess the risk of publication bias. And if you see, the studies are symmetrical, distributed along this final plot. Therefore, there is no risk of publication bias in this study. So then we assess pain at day 1. So this is also the network plot. Chitosan is the most common comparator. And compared to the chitosan, so the pain was significantly higher. Patient received pressure back gauze or pressure back gauze with suture. However, it was a comparable non-significant results when compared to chitosan versus collagen versus collagen with suture. The rankogram shows collagen as the best, followed by chitosan. Then we assess the pain at day 7. We have also 3 comparison here. We have pressure back gauze with suture, pressure back gauze alone. So the pain was higher in patient received the pressure back gauze and suture compared to the chitosan. So chitosan was ranked the first, then followed by pressure back gauze. Basically, it could be inferences that patient who received pressure back gauze and suture, most likely they might have received a surgical extraction rather than a simple extraction. That's why they might have prolonged pain. Then we have the risk of alveolostitis, which is an inflammatory condition that occurs after tooth extraction due to the lysis of the socket. It's not an infectious disease. It is not an infection. So we don't need to prescribe antibiotic for such patient, only analgesic to treat such condition. However, the risk of alveolus here in our case, chitosan was the best one, then followed by platelet-rich fibrin. Platelet-rich fibrin is a blood product where you collect the blood from the patient and you centrifuge it, and then you collect the platelet blood and you place it in the socket, which has growth factors that might enhance the healing as well and reduce the pain. And in summary, it is very vital to check patient history of any systemic condition that might be facing, also drug history, the dietary supplement if they are using, to assess the risk of bleeding before dental intervention. And the bottom line here, do not stop anticoagulant. Always consult the patient physician when required. I'd like to quote this statement: the risk of stopping or reducing these medication include thromboembolism, stroke, MI, far outweigh the consequences of prolonged bleeding that might be controlled after local anesthesia. For example, if a patient with a cardiovascular disease that taking aspirin or taking warfarin, they have an increased risk of stroke and MI. If a bleeding occurs, you can control it with the local hemostatic measures. But in case if you stop the medication, the risk of developing such severe, serious, life-threatening condition is high. So it is very vital that you consult the patient physician before modifying any treatment medication. And if the physician advised to adjust the medication, it should be through the physician, not through the dentist. And most of dental procedures can be done without modifying such medication. Based on our unpublished work, collagen-based agent and chitosan demonstrate superior effectiveness in achieving rapid hemostasis and reducing post-operative complications such as alveolus and pain following tooth extraction in patients who are taking antithrombotic medication. So finally, I would like to thank my team members. I have Rana, student, Layan, Lena, Shahid, and collaborators, faculty members involved, and the funding from the QRNF and Qatar University. If you have any questions, I will be happy to answer. Thank you.
Thanks a lot, Doctor. We have a question from a student.
Go ahead, please.
Saying, what is scaffold?
That's a good question. So basically, a scaffold, you can think of a scaffold as like a ladder. Think of if it is a 3D structure. A 3D structure that you inject a material inside, or it's like a sponge. It's a 3D structure. When you place it in the socket, it preserves its dimension and it absorbs the blood. Then it creates a scaffold where cells can migrate through it. So think of it as a ladder. Is it clear?
Yes, Doctor. Thanks a lot. Another question is in patients who are on direct oral anticoagulants like rivaroxaban. Does the current evidence favor the use of oxidized regenerated cellulose or collagen-based sponges for better socket stabilization? And in what specific scenarios would you choose a fibrin sealant over traditional mechanical agents?
Thank you for this interesting question. So basically, the studies that included that compared the oxidized cellulose is lacking in our network meta-analysis. So overall, the collagen-based agent and the chitosan were the most effective that shows from our study. These can be used, but at the end, the option, the decision is in the clinician hands who can decide whether hemostatic agent that can use. The bottom line that we assess the INR for these patients. If the INR is below 3.5 or below 3, then we can proceed with our procedure, provided our procedure is not invasive. And then we start by applying the pressure gauge, applying the local hemostatic measure. So in our clinic, we do apply Surgicel, we do apply collagen plugs that we have available in our clinic. And also chitosan can be applied. So both, actually, I think most of the hemostatic agent will provide suitable outcomes, will control the bleeding. The preference selecting chitosan probably it is actually does not interfere with the healing comparing to other medication, to other intervention. I hope this answer his query or her query.
Thanks a lot, doctor. We have another question. What if my patient lied about his heart medications and while diagnosing him, he confessed about his heart problems? How do I avoid complications in this case?
So can you repeat the query? If the patient lied about their heart condition, but then they
Yes.
declare during the intervention, they declare it.
Yes.
So it is fundamental that we know the correct, it's patient responsibility to declare the correct history. But during the intervention, before you proceed, if you already started the procedure and then they declare it, then you have to apply local hemostatic measure. If you are done with the extraction, then you have no alternative. You have to apply local hemostatic measure. However, it is fundamental that if a patient taking antithrombotic medication, take the INR 24 hours to 46 hours before the procedure. If the INR is below 3, make sure that you have available at your clinic local hemostatic measures, at least one of them that you can use. Make sure that you have sutures in your clinic to control potential bleeding that might occur. If you suspect the patient is lying or you have concern about the patient medical condition, it is a great idea that you consult the patient physician. Send them a request that this patient require oral surgical procedure under local anesthesia, and then they can tell you about the precautions. They can tell you go ahead with the tooth extraction. There is no risk of bleeding, or they might ask the patient to. They might change the medication that they are using. They might stop the medication, but it is not the responsibility of the dentist. It is the responsibility of the medical physician, and it's not our job to stop the patient. We are not actually authorized to stop patient medication. This is something need to be done through the medical physician. However, I would like to highlight the risk of stopping the medication is significant. If there is a bleeding occurs, this bleeding usually it is minor and it can be controlled by local hemostatic measures. So at the bottom line of the INR is less than 3, you can proceed with the treatment. Provided it is of low or moderate risk, not of a severe risk.
Thanks a lot, Dr. Faez.
Welcome.
And dear Dr. Faez, Saleh, on behalf of the IADS core webinars team, we would like to express our sincere gratitude for your comprehensive session today on hemostatic agents in oral surgery. Your evidence-based insights into clinical applications provided our global community with a clear and practical understanding of managing surgical outcomes. We truly appreciate the high-level expertise and depth you brought to this final session. We look forward to the possibility of collaborating with you again in the future. With best regards, IADS SCORE webinars team. Thanks a lot, Dr. Faez.
Welcome. It is a pleasure and have a nice day.
Thank you.
Welcome.